for the rehabilitation itself, I think we have many things to exchange for knowledge and improve ourselves as well. And we have Dr. Visan. I think you know him already. Yeah, he a big brother of us. Everything rehabilitation here, in him. He a leader of rehabilitation here as well. Okay. From now, I think our team please introduce ourselves first. Okay. So start with Dr. Kikamon.
Good morning again. I'm Dr. Kritkamon. I'm orthopedist. Actually, I'm the arthroplasty surgeons, but I am on behalf of the department. Okay, to welcome you and to join you today. We have a lot of sport case. So even I'm arthroplasty or another specialist in our department, somehow we met the sport injury patients. So we hope we will learn from you also. Okay, and we have the main one of our best physiotherapists to present for us today. Okay, thank you.
Good morning, OSHU teams. My name is Dr. Yunas Dokjan, a medical exercise specialist. My job is provide a safe and individual program for the patient who have medical condition and rehabilitation needs. And we work closely with the rehabilitation center, also the doctor, orthopedic doctors. Nice to meet you today. Thank you.
Good morning. My name is Meta Chawutichun. I am a rehabilitation department manager. Nice to meet you.
Good morning again. So I'm Assistant Professor Visan Kantaranakun. I'm in charge for the academic advisory to the submitted group. As you know, we are group 2, so I'm in charge for all the rehab. May I explain a little bit to you because the sport over here we have separately. I mean, like in the U.S. system, sometimes they are under the orthopedic, which is very good. So they handle most of the case by far. But also at the rehab department, we also have some handling. But in the afternoon, because over here they open sport more than 10 years. Yeah. So over there this afternoon you see another. It may be handling more on the like a functional training or more like a aging sport. But we also look after together for the national athletic or a lot of professional like a badminton or taekwondo or something like that. So I look a lot of on the sport size and then this afternoon you see more on aging sport, something like that. So we cover together. And so just so you can understand the picture. For the Meta, the department manager also involved just a part of, like if you lack of the physical therapy, sometimes we doing together, cooperate together. Yes, okay.
So the next session will be the lecture from the OSSU Kun Chanel. So your topic will be the progressive protocol ACL and meniscus repair, right? Okay, yes. We ready to share? You ready?
Hello. Oh, okay. Slides. Is it, let's see, hang on. Do I do play? Oh, Very good. Wonderful. Well, thank you for having us all. We're excited to be here, and the time that we've been here so far has been so wonderful. So thank you very much for all your hospitality. The topic today is progressive protocols. We'll be talking about both ACL reconstructions and meniscal repairs. If you can't hear me, just let me know. So, all right. So though we're going to talk quite a bit about what we do at OHSU from a protocol standpoint, I did want to talk a bit about the history of ACL protocols. One of the things, obviously, that you are embarking on is quite a bit of change and implementing new change. And I think looking at the history of ACLs, we can kind of see the amount of change that has gone on over the course of decades. And for me, that's been kind of like my career to a certain extent. So this cartoon actually, I think, embodies that. So I've been practicing for more than 20 years. And the things that I used to do 20 years ago are drastically different than what we're doing today. And I think certainly the ACL history is kind of reflective of that. So prior to 1980, I'm going to date myself. So prior to 1980, if you injured your ACL, more than likely it was a career-ending injury. There was really little hope for you being able to return back to sport. And and from a physical therapist standpoint, we really were challenged with knowing what to do. And in 1981, Dr. Frank Noyes was the first one that published an article about a rehabilitation protocol for ACLs. Now, for those of you that do return to sport testing, Dr. Noyes is actually the author of the Noyes hop test, so something that we currently still use today. And so he really is kind of like the godfather of a lot of the ACL research that was done years and years ago. And this was actually the first protocol that I learned. And it was a phase-based approach, but it was based on time. And each phase was about 3 months. And the first phase was 3 months. And back then, they didn't allow any range of motion, any weight bearing. You were in a brace, you were locked in, and you weren't moving at all. And the idea is that a stiff knee was a stable knee. And so kind of like maybe how we treat shoulder instabilities. So the idea that if a shoulder is unstable, we do a procedure in order to stabilize it, and then we immobilize in order to create more stiffness and more stability. And that really was kind of the mentality back then, is let's make sure that that new ACL is nice and stable. We don't want to have any instability, and so we're going to limit all the motion and all the activity for 3 months. Then after that first 3 months, we get into phase 2, and then you're allowed to do some range of motion, and then you're progressively doing some weight bearing. And then by phase 3, which is 6 months after surgery, that's when you finally are beginning to do some strengthening. So again, very, very conservative in comparison to what we do right now. Phase 4, you would be allowed to potentially do a isokinetic strength test to see whether or not you are ready to return to doing some running. But as you might imagine, because of the amount of restriction that you were doing for the first 6 phases or first 6 months, the ability to be able to do that was very limited. And the goal really back then was returning to sport was maybe in 18 months. If you were hitting everything well, then 18 months was the potential for a return to sport. So from my history standpoint, I actually was privileged to be able to work at Cincinnati Sports Medicine for just a few months. And this was back in 1990. And I was very excited because, again, for the last decade, Dr. Noyes and his team at Cincinnati Sports Medicine really were the foundation of all ACL research. And although most of my job involved going to area high schools and helping with their injuries, especially football teams. On every Saturday morning, so football games, American football, were on Friday nights. And so the Friday night football games, then there were lots of injuries that occurred. And so on Saturday morning, they would have a walk-in clinic where you could bring the athletes that were injured, and then it could be evaluated. And this was always the exciting part for me, because then I was back at the main clinic, and Dr. Noyes was one of the doctors that was then evaluating these patients. And so I was kind of like a fly on the wall, and I just wanted to kind of hear what they were talking about and what new research that was going on. And the interesting part was that they weren't talking about their research. They were talking about another doctor, and they were talking about another research article that had just been published. And you could tell that it was very unsettling, because the things that they were recommending was very, very different than what this new article had indicated. The article that came out was literally in 1990. It was the spring of 1990, so it was right before I started at Cincinnati Sports Medicine. And it was by Dr. Shelbourne, who was in Indianapolis, which was basically about an hour and a half away from Cincinnati. And they published this accelerated rehab ACL protocol. And to say that it was shockingly different was an understatement. So the accelerated ACL protocol that they published had very little restriction. So immediately they allowed full weight bearing, no brace. They could move their knee without any restriction. By week 4, they were allowed to do unrestricted strength training. And by week 8, if you passed your isokinetic test at 70%, you were allowed to start to do some return to sport. So in comparison to what the gold standard was, where it was for 3 months you were doing absolutely nothing, this was shockingly different. And of course it was like, well, how can they recommend such a drastically different protocol? And the interesting story is that, so Indianapolis is kind of the big city in the state of Indiana, and Indiana is really quite rural. So, and in the state of Indiana, the sport of basketball was very popular. And so what was happening is these athletes were playing basketball in their rural communities. They would injure their ACL. They would come to Indianapolis in order to have their surgery, but they didn't have any formal physical therapy that they could return to their communities to do. So they were basically given the protocol, which is very similar to the Dr. Noyes protocol, very restrictive. Don't do anything for the first 3 months. And then after the first phase, then come back in and we'll see how you're doing and then progress you. Well, they were coming in and they had not been following any of the rules. They got rid of the brace, they ditched their crutches, they were walking, they were doing exercises, they were starting to play basketball. And obviously this was very concerning to the people that had done the surgery, and obviously gave them guidance not to do that. So what they did was they then started to look at, well, how healthy now is this new ACL? If the ACL was stressed during this extra activity, did the surgery already fail? And so they used this KT1000, which is a method to be able to demonstrate how lax the ACL was. And they found that there wasn't really any laxity in the ACL. So all our idea about how restricted we maybe needed to be during those first phases in order to protect the ACL, maybe that actually really isn't the case. And so this information, again, this was just at the beginning of my career, and it really kind of caused a big chasm in the physical therapy and orthopedic world, because you started to have two different camps. You had the people that had relied on Dr. Noyes and his research, and then you had this brand new research that was challenging the status quo, something very different. But patients began to know that there was this accelerated rehab protocol, and so they would start to shop around for the doctor that would give them the accelerated. And from a physical therapy standpoint, there started to be almost pressure to see how quickly could we get patients back to sport. Oh, I can get them back to full, basketball in 9 weeks. And so it was just it was a significant, change in difference compared to what we were used to. Well, then, unfortunately, within over the course of a decade, we learned more about the implication of an accelerated rehab program protocol. And although the ACL itself didn't seem to be more lax from that increased activity, the injury rate during that first year was quite high. So 25% of people that went back to sport within the first year ended up re-injuring. So obviously we were missing something. It wasn't just about the laxity of the ACL that was the challenge. So the focus from a physical therapy standpoint then started to shift towards, well, what types of exercises are better to prepare the knee in order for a return to sport? And really functional-based exercises, closed-chain exercises gained a lot of popularity. The early range of motion and the early weight bearing from the accelerated program did stay. So I think that was a huge change from the previous program. But closed kinetic chain exercises, no open kinetic chain, that was considered still too risky. And then increase in the amount of proprioception balance related training was also kind of highlighted during this time. Maybe there was something about knowing the joint, knowing where it was in space that needed to be trained better in order to prevent the potential for re-injury. And then previously, the return to sport was focused more on the isokinetic testing. And they started to look at additional tests and other things that we could do to determine whether or not the knee was really ready to return back to sport. So then by the mid-2010s, more information, more research, of course, is coming out. And the restriction on open chain exercise started to be challenged. And again, this was you definitely had physical therapists that were in one camp of no, only closed kinetic chain, and other people that were more supportive of open kinetic chain because you could isolate the quad. And quad strength seems to be the thing that lagged the most in regard to trying to get people back to their sport. The use of electric stimulation in those early phases started to be utilized more. So if somebody was having a hard time getting their quad active, we would use that in order to get the quad active and hopefully then again minimize any quad atrophy. Research was coming out about the role of the hip in controlling knee valgus, and so that became more of the focus. Post-op braces, not necessarily post-op braces, I guess eventually with sport, but early on, using a post-op brace for weeks at a time was kind of common, and by the mid-2010, that kind of went by the wayside. And then 2010s was right when blood flow restrictions, some of the research were just coming out. It certainly wasn't standard. It certainly wasn't prevalent, but that's when it kind of first started to be published. And then again, there was more of a cluster of testing that was done to determine return to sport. In addition, I think one of the other things that we looked at from a research standpoint was preparing a patient well prior to surgery. So prehab was really done only for those patients that were limited with their knee extension. So if you didn't have full knee extension, then you would do maybe PT in order to get that full knee extension before surgery. But even having at least one visit to prepare a patient prior to surgery had high value. So that became part of the norm. So here we are today. Obviously, a lot has changed over the course of a number of decades, but I find it really interesting to just how we got here. Currently, from a protocol standpoint, our protocol is certainly there's a time component, but moving from one phase to the next is really based on criteria. So do you have full knee extension? That might be the first criteria before you move to the next phase. So a phase-based protocol as opposed to just a time-based protocol. Certainly blood flow restriction has now become more of a standard practice. The research around NMES really now indicates that in the past it was, can I activate my quad? If I can activate my quad, I don't need NMES. Now all the research indicates that everybody should have NMES using eStim on a daily basis for the first 6 weeks. Those patients that have that and do that program do much better than the people that do not. Resisted open chain exercises now has been brought into the fold. That should be standard practice. Certainly people that are resistant to that aren't really keeping up with the research. That is the best way of isolating the quad. And again, quad strength still continues to be one of the things that can slow return to activity down. Certainly hip strengthening, neuromuscular, again, proprioceptive activities, doing dual task activities. So I think about dual task as, we need balance and we need proprioception when we're not actually thinking about it. So if we're doing an isolated proprioceptive exercise, well, you can really think about your proprioception, you can think about your balance, but in real life, we're not really thinking about balance when we're needing the balance. And so doing more dual task activities is really, so I might be doing a balance exercise and I could be counting backwards from 100, or I could be throwing a ball against the wall, or somebody's throwing flashcards at me and I have to determine what the number or the color is. So my brain is distracted from the activity, not necessarily focus on that balance activity. We continue to do a cluster of return to sport testing. I think the additional aspect of psychological readiness, so not just physically is everything looking like they're ready to go, but psychologically, do they feel ready to go? And to really listen to that. So sometimes maybe there's something that we can't measure that is indicating that they're not really quite ready, and really listening to that. And then currently we are at the state where, from a research standpoint, it appears that really 9 months is the threshold as far as return to sport. If we return people to sport earlier than 9 months, even if they've passed all their tests, the risk for re-injury is higher. So that's kind of the cliff notes of where we kind of stand today. Well, I'll kind of go through specifically now from an OHSU standpoint what our protocol looks like, but that's kind of the cliff notes of where we're at. Ooh, I want to talk a little bit too about, so while the physical therapists were obviously doing all these changes with their protocols, then there was the aspect of the surgeon side, right? So way back when, they didn't even do an intra-articular surgical procedure, it was extra-articular. And then we went to bone, tendon, bone with the middle third of the patella tendon. That was the gold standard for a long time. They looked at double bundled graft structure, hamstring graft, allograft. They changed the slope of the angle in order to minimize the stress on the ACL. They put plasma in there in order to help improve the health of the ACL. The newest one, we have one of our surgeons here at OHSU that is doing the BEAR procedure, this bridge enhanced ACL. And so rather than, I got a slide here, rather than actually putting a brand new graft in, they take the ends of the injured ACL, they have a scaffolding or bridge that they use to connect each end. They have some blood product in there in order to help facilitate healing, and then that becomes the new healed ACL. I will say the interesting thing with working with so obviously this is research, and so we as the physical therapist have to follow what the research protocol indicates. But from the research protocol for this, it is quite conservative again, much more conservative than what we would typically do, like if we had like a hamstring tendon graft. So again, lots of information as far as like new things that have been developed over time. And yet despite all of this, we're still, I don't think, really hitting the mark. The research indicates that up to 35% of athletes do not return to their prior level of function, and up to 22% injure their ACL within the next 5 years, and 24% on the opposite side within 5 years. So like I always, when I read some of these statistics, I'm like, what are we missing? There's still something that we are missing, that we have maybe more to learn, more to test, more to determine whether or not we can influence that and make that improve. So from a historical perspective at ACLs, obviously there's been significant pendulum swings from a very conservative into very aggressive, and now finding kind of that middle ground. I think what that really highlights is how important it is to stay up to date on the research, to read the research and challenge the research. Does that make sense as to how you're thinking or visualizing what is happening? We use PubMed.gov as kind of our database for determining or looking into the updated research. And I think one of the things that I'm impressed with is how collaborative you are, and I think that that's really important moving forward as you're looking at new research. And as much as you might have a action plan for now to move forward to new change, that is a dynamic process, and that you're continuing to look at additional research. So from an OHSU standpoint, kind of the specifics of OHSU, how we use protocols. So I know that there are some protocols out there that are very specific as far as like in phase, 2 at week, 3, we are going to do these specific exercises. And we don't necessarily use protocols quite like that. The protocol kind of sets up the restrictions. Is there a restriction in the range of motion or the weight bearing? Is there tissue stress that we have to account for? Is there a brace or no brace? And then the specifics of what's inside the box, the quad strength, the hamstring strength, the hip strength, the balance, that's really kind of up to the physical therapist to decide what to use. And from an exercise prescription standpoint, it really is like, what does the protocol allow and what does that specific patient need? And then are the exercises that you're prescribing meeting the need of what our goal is? The brain is smart, and oftentimes we give an exercise for a specific thing, and we're realizing that they're able to compensate, and we might have had that exercise for quad strength, and now they're using their hip way too much. So we need to find a different exercise in order to accomplish what we want to accomplish. From a scheduling and structure standpoint, just again to kind of highlight maybe some of the difference, all of our patients get a pre-op visit. Some of our patients, and we have one surgeon that wants the physical therapist to come in on the day of surgery in recovery room and review the exercises with them. They begin their home exercises immediately the day of surgery. So we do not have this rest recovery for days before you start moving. We want them moving immediately. Worst case scenario is we would see somebody at worst 10 days after surgery. We really try to get them, anywhere from 4 to 7 days immediately after surgery. So really the impetus is on them immediately after surgery to start those exercises right away. And then from a frequency standpoint, we see patients, we look at this as a marathon. So patients are coming to us for the course of their treatment. So hopefully for the full 9 months. So we are given a certain number of visits, and we have to then decide how we're going to use those visits. Generally speaking, we might see them early on 1 time a week, and then as things progress, and we start to stretch out those number of visits. So as such, a good amount of emphasis is on us being the consultant to the patient to give them the information that they need in order to do the exercises really kind of on their own. So from a pre-op visit standpoint, this is exactly what we do from a pre-op visit. This is the only time that we are really prescriptive from an exercise standpoint. Both our ACLs as well as our meniscal repair patients get this set of exercises. There's some things I don't really love about this, but this is something that has been blessed by our doctors, so this is the one that we give. I do have a tendency of liking early on to do longer heel props and longer prone hangs in order to get that full knee extension. But on the initial visit, this pre-op visit, we go through these exercises. We certainly talk about what the patient's goal is. If they're wanting to get back to playing soccer, that's the carrot that we have dangling out in front of them, and to get them motivated to do the exercises again right out of the bat. Most of the questions that the patients have are how long is it going to take me to get back to sport? And this is our opportunity to talk about, it's not about just time. So the earliest would be 9 months, but whether or not you're ready to go at 9 months will be based on whether or not you're doing the exercise program. And so hopefully motivating them. If they've not used crutches before, certainly we educate them on using crutches. We'll get their post-op visits all set up. I will also say, probably in addition on this list, is if we recommend that patients order an NMES and E-stim unit, so that when they are have had surgery, that they're starting to use that home NMES unit right away. Sometimes if we have time, we will actually practice it in that same visit, so they have a sense as to what it should feel like. So, and then I think from a messaging standpoint, the key is really, you have surgery, there's going to be pain. That is normal. And many times when people have pain, there's that stop sign in your brain, like that must be bad to move. If it hurts more, do less. And we come along with the complete opposite message, that hurt does not mean harm. And really, from a standpoint of physical therapy, the movement is the medicine. And so when you're hurting more, it might be because you're not moving enough. And get them thinking about that, because I will say there will be a point immediately after your surgery that you're like looking at these exercises and thinking, certainly my knee hurts so much, I should not be doing these. And that's when I want you to remember this, that hurt does not mean harm, and just go ahead and do the exercises. And oftentimes when you do the exercises, it starts to feel better. So getting people into that mentality early is really helpful. From an immediate post-op standpoint, our surgeons use a nerve block. One uses an adductor nerve block so they don't lose quad function. The others use a femoral nerve block, so for the first 24 hours, quad activation might be limited. Certainly that's an opportunity from a pain standpoint to take full advantage of the nerve block in order to work on that knee extension. In addition, they'll have a pain pump for the first 3 days. Again, maximal pain limitations so that we can kind of get those exercises going. For those that have the femoral nerve block and their quad is not very active, we do have a post-op brace. It's just kind of like an immobilizer, and that's only for the first, hopefully, day when their quad isn't active, and it's only for obviously when they're weight bearing. But as soon as their quad is active, we get rid of the brace. And as soon as they can walk without a limp, we're going to get rid of the crutches. And again, they're going to be starting the exercises the day of surgery. So from a specific protocol standpoint, this is kind of we'll go through each phase and mapping out what our protocol looks like. For the first 2 weeks, really it is exactly what I kind of showed you. So they're going through those exercises. They will come in. If they can bring that home E-stim unit, we'll be utilizing that home E-stim unit. It really depends upon whether or not somebody's range of motion is doing well. If they have great full knee extension, then we can progress with some of the exercises. If they're not getting great full knee extension, then we probably are focusing more on that. So from a criteria standpoint, I will emphasize the straight and strong. The first couple of weeks, our goal is get that full knee extension and get that quad firing. If they don't have full knee extension, we're going to wait until we get full knee extension before we progress into the next phase. Then phase 2 is really, again, another couple of weeks. We're kind of progressing a bit more. At this phase, we're certainly utilizing blood flow restriction. So it's too early yet to really load. And so we're going to be using blood flow restriction in order to help facilitate quad strengthening. Again, although we have a list of activities, exercises that are there, it really does depend upon the specific patient and where they are at. But we're at this phase. They hopefully are off of the crutches. They have excellent full knee extension. Their quad is firing, but we're still using the NMES. We're starting to progressively do maybe some double leg exercises, but using that blood flow restriction. And the bike is your friend. If someone's knee hurt, put them on the bike and get that bike moving, and they always will feel better. So our criteria to move on from this is really just a little bit more knee flexion range of motion, certainly hopefully minimizing any gait abnormalities at this point. I call this third phase kind of the bread and butter phase. This is where we're really starting to progress from a strengthening standpoint, starting to do more loading. hopefully, so by week 6, we are no longer using the NMES. So you use NMES until week 6. And then progressively, we're starting to use the blood flow restriction less, and we're using more loading exercises. I will highlight that from a loading standpoint, we go from kind of double limb exercises to single limb. So we really want to eventually do single leg presses, single leg extensions, single leg curls. Our physicians do want to limit the range of motion of open chain leg extension. So we limit from 90 to 30 degrees. And again, a variety of different exercises that the physical therapists themselves can choose from. So once we get towards the end of this phase, so we are at about 12 weeks. Again, they should have great range of motion. They should have good quad control. They could go down an 8-inch step. And then this is when we can do an isokinetic knee test to see whether or not they have enough strength to progress to the next phase, which involves running. During this phase, again, I call it the bread and butter because we're progressively trying to load, and sometimes we may hit the gas a little too quickly, and then someone might get a little bit more swollen and sore, and that's an indication that we're maybe going a little too fast. So really kind of paying attention to the knee swelling and soreness as an indication as to whether or not the knee is tolerating what they're doing. Hang on a second here, and let me get up. Okay. So if someone passes the test, and I will say that it is okay if they don't. You know, from an overall protocol standpoint, again, the length of time is 9 months. So we're anticipating 9 months, and yet we're doing some isokinetic testing at 3 months. So we're just a third of the way in. So if by chance somebody doesn't pass the test, it doesn't mean that there's something drastically wrong. We certainly, you know, will then look at the test and utilize the information from the test to decide maybe what we're needing to change our focus on. But as we're getting into this phase, then we're starting to do more jogging, some agility activities, some plyometrics. Again, the specific exercises are based a little bit geared towards what the patient is going to eventually want to do. I think, again, this is the phase where everybody's really excited. Yay, I get to run, I get to jump, I get to cut. And they sometimes stop doing those foundational strengthening exercises that got them there. And so I think that that's a really important point that I kind of communicate. Number one, we're still only a third of the way into the protocol. Yes, you're going to do some more fun activities, but it's really important that the foundation from a time and emphasis standpoint is on that strengthening. So at the end of this phase, we're at about 6 months, and that is when we will do a little bit more testing, where we'll do that noise hop test and the Y balance. And again, we're looking for about 75% limb symmetry to see if they're ready to advance to the next phase. The information that we gather from those tests does give us, if they don't pass, it gives us information about how then we should adjust the program. If they are landing with the jump test and they might be losing power because they have so much knee valgus that they're having a hard time controlling. Okay, maybe I need to look more at their hip strength and their proprioception. So we're utilizing the even if they don't pass the test, we're still utilizing the information from the test in order to kind of guide what we're going to do next. This is just an example of the progression of walk jog that we use. I know that there's quite a bit out there, but this is just an example. And then our next phase is really starting to go, if they pass the noise, jumping, and the Y balance, then we get to do even more fun things where we're getting sports specific. And so not just general jumping, now we're looking at, okay, what specific sport activities do you want to get back to doing? And then the deciding factor, are they done with us? Are they discharged from therapy and are ready to return? Is this battery of tests where it's, again, 90% limb symmetry for the hop test, the isokinetic test, the Y balance. We use the drop down jump test in order to, again, more from a from a subjective standpoint, look at how their control of knee valgus is. And again, like I mentioned, that psychological readiness, does the athlete, does the patient really feel like they're actually ready to go back to sport? And even if they passed all of these things, if it's at 8 months, we're not quite ready to go, we will recommend that they wait until 9 months in order to return to full sport. So that's our ACL kind of protocol. And so we'll kind of shift gears to the meniscal repairs. The challenge with meniscal repairs is that they don't happen much in isolation. And as such, we don't necessarily have as much information research about them. When they do happen, they often happen in combination with ACL. And what our protocol generally is, I'll just say generally, because we have some variability, but generally is that if there's any kind of restriction, so weight-bearing range of motion because of the meniscal repair, we follow the kind of first protective phase of the meniscal repair, and then after that, then follow the ACL protocol for the rest. So now, since the time when our Thai cohort came to Oregon, and today, there's been a new research article that came out. So again, change happens. And so just a month ago, this consensus study came out from orthopedic surgeons and physical therapists in the United States and the UK. They did a review of all the research to kind of answer specific questions. So they looked at maybe like 19 different questions, like how much range of motion should they be allowed? What kind of exercises should we limit weight bearing? How do we progress the phases? So they had 19 different questions that they had that they wanted answers for, and then they looked into the research in order to get answers. The interesting thing is they almost from right out of the gate indicated that they don't have a lot of great evidence. So they categorized the evidence from A to D as far as quality, and of the 19 questions they addressed, 17 had D level evidence. So again, it's kind of just an indication that we don't have great evidence in order to make great decisions, but this is the best that we have right now. So I took a couple of the slides from the article themselves that were nice summaries. And really what the take-home message was as far as should we limit range of motion, should we limit weight bearing, was based on the type of tear. And so if there was more of a vertical tear, then you could allow full weight bearing. You had no need for crutches, no restriction on the range of motion. And then the more progressive, if you get to more of a transverse horizontal route, then we're looking at implementing more range of motion restrictions, weight bearing restrictions. It was interesting that other than the meniscectomy, they didn't find anything specifically addressing the brace. And yet, obviously, if you're limiting range of motion, you're probably wearing some type of a brace. But there wasn't specifically anything in the research that pointed to that. The other aspect that they kind of looked at was these phases of rehab. And they broke it down to 3 basic phases. So the protective phase, the restorative phase, and then the return to sport or activity phase. And then they specified what was the criteria for progressing from one phase to the other. So you protective phase, obviously, if you just had the vertical, there would be really no protective timeline. So as soon as a person had full range of motion and no swelling and good quad control, they could right away progress to the restorative phase. So certainly the type of repair, injury and repair that was done indicates how long you're kind of in that early phase, and then certainly then getting that full range of motion, good quad activation. Progressing from the restorative phase to the return to sport phase, the goal was to have full range of motion, 80% muscle strength, and they indicated adequate dynamic knee control without necessarily an indication as to how to test that. So, but just from a qualitative standpoint. And then the return to sport phase, their specific return to sport was based on an isokinetic test and the jump test. And then from a duration standpoint, it really, again, was based on the type of tear and therefore the type of restriction. If you had a vertical tear, you could get back as early as 4 months, and the more complex tears, then looking at 6 to 9 months. A few of the other things that they mentioned had fairly good support was, again, the use of NMES, as we know kind of from our ACLs, use of cryotherapy for swelling, minimizing the deep squatting, jumping rotational activities for the first 4 months. And again, they looked at this return to sports testing. Their testing cluster was isokinetic testing and then that hop test. So we'll kind of briefly go through what our protocol is, but I will say we have new information. And so this is something that we will be looking at within our team and the information and how we can change our protocol. But that is the exciting part of being a dynamic team and having to change things as obviously the research comes through. So certainly in the first 6 weeks could be the protective phase. And basically for us, we just look at the op note. We do have one physician that I will say even for the more complex tears, he will not necessarily limit range of motion or weight bearing. So he's much more progressive. And then we have other surgeons that even for what we might consider a more simple repair, they are restricting the range of motion and they are restricting the weight bearing. So we really let the surgical note kind of guide what we're restricting and for how long in that first phase. Again, during this phase, we're going to use that NMES. We're going to use our blood flow restriction, especially if they're restricted from being able to utilize load. Again, the specific exercises that we are doing is really based on what the patient needs, letting the physical therapist kind of guide that based on the patient. The next phase, by week 6, we are generally out of any restriction. And so we're progressively working on the range of motion, working on return of normal gait and weight bearing. Our general tendency is to still have the post-op brace on, to open up the brace as they're demonstrating how much active range of motion control they have. So sometimes, you have a patient that is restricted to 90 degrees and then they're allowed to do more and they immediately have full range of motion and good control, and then we can wean them from the brace. Some people are a little stiffer and they go from 90 to 95. And so when we see that, then we might just open the brace just progressively as they're demonstrating an increase in range of motion. Again, from an exercise standpoint, we're now starting to get hopefully a little bit away from using the blood flow restriction. We're doing more loading. From a load standpoint, again, we're kind of keeping a little bit shallow with our double leg or like a squat exercise. We don't want to go into that deeper squat activity. But again, from a specific exercise standpoint, we're kind of letting the physical therapist kind of decide. And we have a long phase from week 10 to 5 months. And again, it is really working on those foundational things of strength, proprioception, and balance. Again, letting the physical therapist kind of indicate what specific kind of exercises that we're utilizing. Hopefully we're doing more load, and we're now allowing to do a little bit deeper as far as the depth of the squat is concerned. Patellofemoral things, both with ACLs and with meniscal repairs, are something that we're always kind of monitoring in this phase. At the end of this phase, we're looking at, again, doing an isokinetic test to see whether or not they're ready to do some additional running. By month 5, hopefully, if they've passed that isokinetic test, then we start to do our maybe walk jog. We're initiating some agility exercises, some plyometrics. Again, kind of letting the physical therapist kind of guide what that patient specific needs. At the end of this phase, where we usually use the same battery of tests, so the limb symmetry of 90% for our isokinetic test, our jump test, the Y balance test. We have this additional phase in here because sometimes people, again, aren't quite ready from a return to sport standpoint. So we're doing more specific sport training activities for this phase. So certainly looking at our meniscal protocol with respect to what the recommendation is, I think there's some things from a structural standpoint. I like the idea of having like 3 phases instead of the higher number of phases, but we will collaborate and see what the team all comes up with. So I think the takeaway message from today's presentation is really that things really change. And as much as we are, you're going to initiate some action plans for some of the new things that you'll be implementing, continuing to collaborate, watching the research, implementing those things, come to some group consensus as far as the things that you need to implement. And that's really what makes it exciting. Thank you very much.
Thank you very much. Very easy to understand and follow. Anyone have question for the speaker? Don't be shy.
Yes, สวัสดีครับ Good morning. I am Ping from Bangkok.